Welcome back once again, and here we are. We're going to start talking a little bit about some case reviews. So we're going to look at the Doppler interpretation of some cases. No disclosures to make, and topics. We're going to talk about angle correction, something about the velocity parameters we've reviewed earlier. Which one do you use? Is there a consensus, and review kind of how to interpret the case. Talk a little bit about ratios, ICA to CCA ratios, and something about the common carotid artery. We always forget about the common carotid artery. It's so lonely, it needs more attention. So we'll talk about common carotid artery grading of disease. This is two questions. Some of you, actually, when you ask this question to large groups of people, do you believe that angle correction should always be set with the cursor at 60 degrees versus it can't be set lower than 60 degrees? Most people answer number two. They say there's flexibility in doing the Doppler angle correction. But let me show you this one first case, okay? Here is a case where the angle correction is set at 60 degrees. Here's the angle correction right there. We're obtaining a velocity of 144 centimeters per second. Same patient, same location, but this time we've set the angle correction at 40 degrees, and we've gotten 58 centimeters per second. So we have two different velocities. Now, remember, Dr. Pellerito said 125. So here we have one measurement at 144 and the other one at 58. So which one would you use? Now, I will show you the correct answer. And I want you to think, because a third of you will have picked the one you're not supposed to pick. As we've seen that. The correct interpretation is the less than 50% stenosis with the angle correction aligned parallel to the direction of blood flow, and that was the 40-degree one. That's the correct one. It's lined up properly in the direction of flow. Because I use that word 60 degrees, a lot of people still get fixated on that's better, even if it's completely incorrectly positioned in the lumen of this one case. Okay. Next step is velocity parameters. Which one do you use? I mean, these are your three current options. Peak systolic velocity at the point of narrowing, end diastolic velocity at the point of narrowing, and the velocity ratio, this point divided by the peak systolic velocity in the common carotid artery. Now, question becomes, overall, which is the most commonly used velocity criterion for making a diagnosis of carotid stenosis? These are your three options. When we survey people, and when the ICAVL, also called ACAVL, surveys different laboratories, the majority, almost unanimous, come out with the peak systolic velocity. That's the velocity criteria we believe in the most, the one that's more robust, supposedly. Now, the next step of the interpretation is obviously to ask the question, at what level? If you look at the literature over the years, this peak systolic velocity ratio that corresponds to a 50% diameter stenosis has varied anywhere between 110 to 150. The current value, just to confirm, should be 125. There are some people more currently that are debating whether 150 should not be used because it reflects more the current level of stenosis. And the 125 is really kind of a screening level. It's a level that we've picked to make sure we don't miss something. You know, we want to make sure we capture people with stenosis. We just don't want to miss those people. So better to have more people that are falsely positive that we think have greater than 50 or actually less than 50 than to miss the people that are greater than 50. Now, the next question is about 70% diameter stenosis. Here the literature has varied mostly between 225 and 250. Now, a good middle range is what's been adopted from the consensus meeting from the Society of Radiologists and Ultrasound. And it's a robust number. It seems to work. And it works for 70% diameter stenosis. That leaves us with one of the other criteria that we want to use is the velocity ratio. Here you have an option. Remember, you measure the velocity ratio here in the common carotid right before the bifurcation and at the point of maximal narrowing. And the question is, what ratio is best suited for a 70% diameter stenosis? Now, before we make that decision, it really, in the literature, we only really have data for 70% stenosis. I could have asked a question for 50, and a lot of people will say 2. But there's no real solid data using that velocity ratio of 2. What we do have is 4 for 70% stenosis. Okay. So these are their velocity criteria, and they come from the SRU Consensus Conference, which is a group of surgeons, sonographers, radiologists, cardiologists, vascular medicine that came together and kind of put down, as Dr. Pelleru indicated earlier today, some numbers that can be of general utility to most of us in the field. And it seemed to work. So let's do another case. Patient has his distal common carotid artery peak systolic velocity of 66. That's within normal range. The color Doppler looks okay. A little bit of an arrhythmia. Doesn't affect us too much. It stabilizes during the examination. We find the stenosis, a point where the velocity is 139 centimeters per second. We also do a velocity ratio, 139 divided by 66, which is 2.1. Okay. And we sample distal just to make sure that there's no second lesion more downstream, and what we get is basically a normal decrease in velocity with distance from the stenosis. So here are the data. Peak systolic velocity, 139. Velocity ratio, 2.1. What degree of stenosis would you report? Now, if you are consistent and you use peak systolic velocity ratio, at least at the SRU Consensus Conference, then 2 would be your cut point for 50. If you use peak systolic velocity and you're basically also using the same consensus, then that will also give you 50. So there can only be one answer in this context, 50 to 69% diameter stenosis. Now, what I've put down here is close to 50%. And there's a reason for this. Because 125 to 139 is very close. That patient comes back in 6 months, they could be at 125 or 124. So we want to indicate to the clinician, this is not 50 to 69, but close to 70. This is something in the lower range, okay? It's closer to 50. Now, some people would have just said 50 to 69%. That's an okay option. Those are the 2 major options for the interpretation of this one case. And the reason why I would stay closer to the 50% cut point is because of this 2.1 ratio. It's kind of a lower. Okay. If it had been 2.5 or 2.6, I think people would just say 50 to 69. Now, proximal internal carotid artery velocity is 167. Okay, 167. I'll tell you that the common carotid artery velocities in this case are completely normal. So, there's calcified plaque. You can't get underneath it, but the waveform is relatively sharp. There's no post-stenotic turbulence we talked about today, so there's no lesion hiding underneath the calcified plaque. We just can't see it that much. We only have a velocity elevation to 167. So how would you interpret that? Now you have 3 options, less than 50, 50 to 69, and 50 to 69, but close to 50. Now, 167 and 125, we're starting to see a big shift in the difference, right? And remember, it's 50 to 69 is 125 to 230. Now, to my math, 167 is very close to the middle of that range. So I would feel very comfortable with the following option, 50 to 69% diameter stenosis. I think that would make sense and be consistent with interpreting this one case. Okay. By the way, many of these cases have been shown before to other groups of people to get a consensus, and this is more or less where we have ended up. Here's a patient, echolucent plaque. Velocities in the common carotid are normal, but the proximal internal carotid artery has a velocity of 205 centimeters per second. So, how would you report this one case? You have the option of 50 to 69, 50 to 69%, but close to 70, and 70 to 99% stenosis. Here's a little bit give and take. There are 2 major answers that take place here. It's either going to be 50 to 69% diameter stenosis, and some people would start to wiggle a little bit and say, listen, I'm really getting close to 70. I really want to communicate that to the referring clinician. Actually, the difference between 205 and 230 is 2 cups of coffee as far as I'm concerned. I mean, you know, you position yourself slightly differently. I'm sure you could get it to 230 if you wanted to. So to me, it's very close. And when we survey most people who see this one case, they tend to go along with this interpretation. It's close to 70, but 50 to 69 is perfectly acceptable as a standard of interpretation for this one case, for this velocity range. Another case. Now, the distal common carotid artery is 73 centimeters per second. 73 centimeters per second. The proximal internal carotid artery is 128 centimeters per second. And I always show the distal internal carotid artery to make sure there's not a second lesion, but to make sure we're out of the flow disturbance, that there are no surprises, or that it's not a long diffuse stenosis, because they can occur. And you should document the velocity in the distal internal carotid artery. And I will show you a case why it's very important coming up as when we get to the other lesions that evolve here, okay? So, what we have, peak systolic velocity 127, ICA end diastolic velocity 48, I'll give it to you here, and the ICA CCA ratio of 1.74. So those are your values. Okay? Now, how do you report this lesion? So these are your data. Here's the tricky part. You've got to be consistent. Okay? You've got to be consistent. So, if you're going to use the peak systolic velocity, right, it's higher than 125, unfortunately. So I'm going to have to say 50 to 69, or close to 50. I say close to 50 just to make sure that you know. Because you know what, that patient can come back in 6 months and get 112, 115, 120, you know. It really varies. Now, if you use the peak systolic velocity, that's probably the way you should interpret this case. Although you can always say 50 to 69, but you're probably not transmitting a key piece of information to the referring clinician. If you use velocity ratios, you should have interpreted this case as being less than 50% stenosis, but close to 50, because it's 1.7, not quite 2. So it depends which criteria. Now, this is an important point, because when you list your criteria for interpretation, you say, I do this first, I do this second, I do this third. And in some cases, you say, if my peak systolic velocity is close to 125, I would rely on the velocity ratio. If the heart rate is very variable, I will use the velocity ratio. So if you had used the velocity ratio on this patient, you would have been perfectly legitimate. But in order to be consistent, because if this test were to be reviewed by someone else, they say, wait, why did you use this when you told me when there's a little bit of an arrhythmia or something that I should use the velocity ratio? And that's the case here. Okay, another case. This is actually an external carotid artery, and the velocity here is 400. This is not the greatest angle correction. Okay, I'll give you that. But even if you tried to angle correct it, you'd still get something above 300. Okay, you can give me that. I mean, I just picked these cases off of the work list of the lab just to give you some examples. So greater than 300 centimeters per second. Okay, this is the external carotid artery. So how would you report it? Would you say, I'm not going to tell anybody, this is a secret. 2, there is a stenosis. Hello, this is California. Report greater than 50% stenosis. And finally, greater than 70% stenosis. You can always say, hang loose from Maui, right? But that's, so which of these 4 options? And you can always say number 5. Oh, that's number 1, do not report. Walk away from the case. Now, here's the irony of this. You ready for this? There is a stenosis. There are no velocity criteria out in the literature that are consistently applied to the external carotid artery. However, it's a key piece of clinical information, I mean, to complement the evaluation. Very often, a patient will present with a carotid bruit. And the bruit could have been generated from the external carotid artery, and the internal is completely normal. The clinician needs to know this. So I use the expression, there is a stenosis, but the indication is there's a flow disturbance consistent with a stenosis in the proximal external carotid artery that can explain the presence of a carotid bruit. And that's an important piece of information that should be transmitted. Case number 6. So we have a site of aliasing in the internal carotid artery, right there. We have a velocity of 85 centimeters per second. We have, at the site of aliasing, about 119. A little bit downstream, close to some spectral broadening, about 125. Subtle differences. Sometimes, you know, that point of maximal velocity can vary a little bit in the course of the artery. And here you are. How would you interpret this? Less than 50% diameter stenosis, less than 50% but close to 50, 50 to 69, or 50 to 69. So 4 options. And now I will get you off the hook because the majority of people would answer these 2. They're going to waffle. They're going to waffle a little bit because they're not quite sure if it's 119, 125, you're very close. You want to communicate you're close to that cut point. Now, these cases, some of these cases actually were discussed in panel. I think this one was discussed, and it's one of the first cases that I brought up in front of a panel of relatively renowned vascular interpreters who have always argued for these cut points. Say, oh, above this, it has to be 50 to 69. Below, it has to be so-and-so. But when you show them the case in the panel, and you say, how would you interpret it? How would you communicate the fact that it's really close to that cut point? Then they would use the expression close to 50%, okay? So either one is, I think, acceptable, but it has to communicate that that patient does need to be watched more closely over time because we do monitor these stenosis. When they get to about 50%, some recommendations are that you should follow them yearly. Others say 6 months. It really depends on the state where you are. We basically do about every year when you get close to this point. So another case. This one has got more extensive, kind of dense plaque, some calcific elements, near wall, partly there. So there is some lumen narrowing here. We're seeing evidence of that. We got some aliasing. We have a peak systolic velocity of 153. Whew. We're out of the 125. I feel better already, so we're not going to. So what do we got next coming up? Well, we have the common carotid artery with 78 centimeters per second. So you have a peak systolic velocity of 153 centimeters per second and a ratio of 1.96. Talk about splitting hairs. Well, if your primary criterion is peak systolic velocity, these are one of the 2 ways you can interpret it. I would probably at this point say 50 to 69. If you're a velocity ratio person, oh, that shouldn't have worked that way. It should be here. No, there it is. Okay. Actually, peak systolic velocity. Let's go back. I misread the colors here. Sorry about that. I was so clever. Yellow up here is 1.96, correct? No one booed me. That's very good. It's very good. What it should be is less than 50% stenosis, close to 50, because it's just below that 2. And we could have taken one of these 2 interpretations. This is probably inaccurate. But if we take the 153, right, then I don't think there's any doubt that it's 50 to 69%. So I apologize for the confusion on this one. You know, when there's yellow and white all over the place, you know, when you're preparing these slides, you can get confused. So case number 8. I hope the next ones are not as confusing because maybe I'm developing color blindness or something. Anyway, 235 centimeters per second. So that should be, whoa, that's close to 230, so you know I'm going to play a game here. Peak systolic velocity, 63 in a common. So we'll do the ratio. I'll do the math for you, just so you don't have to do the math. I know some of you can do it. And here we'll have 5 different options. Now, it depends what your primary criterion is going to be here. So 234 is really close to that 70% stenosis background. So people could argue it's close to this. You could make an argument to use this as well. I won't object to it, but if you are interpreting according to your criteria, if it says in your manual 230 or above, then you probably have to use what I'm outlining here, 70 to 99%, because if you're not using it, you're going against your criteria that you've listed, okay? It's a technical point, but you have to be very careful about this. Now, if you're using 4 as a cut point, which is very common out there, then you're stuck doing 50 to 69% because it's less than 4. I would probably add close to 70% for the following reason. That peak systolic velocity is up there, okay? So you're allowed to do that. So you're staying within your range, and you're qualifying it a little bit. And that's, again, an important message to the clinician. Case number 9. Well, this one's easy. Peak systolic velocity is all the way up there, 492. So we're away from 125. We're away from 230. End diastolic velocity is 164. And in the common carotid artery, we have a peak systolic velocity. It's a bit elevated at 123. So why don't we do our ratios? So we have peak systolic velocity 492, end diastolic velocity of 164, and we also have a ratio, believe it or not, at 4. Well, that's a bit tricky. I told you that common carotid artery velocity is going to come back and hurt us. So which one is it? Which one is it? Well, if you use 492, and potentially in combination with this, you're probably safe using this. Okay, so this would be perfectly acceptable. Okay, so 70, or I use 99, but that means to near total occlusion, right? That's what we really mean, near total. It could be 95. It's just a way of kind of telling really high-grade lesion. However, as Dr. Pellerito mentioned earlier, an alternative, which is accepted, actually has more specificity. We're communicating the fact that it's even more than 70, it's more than 80, because the end diastolic velocity is greater than 140. And that's a value that's been used by, very often, for an operative threshold for asymptomatic patients. Now, there was a study called ACAS where they showed that there was a benefit for surgery for asymptomatic individuals with 60% diameter narrowing of the internal carotid artery or more. The problem with this study is because of the way the patients were screened, what they called 60% is probably more than that. And most surgeons that understand this study have said, listen, 60% doesn't make sense because we're operating on symptomatics at 70%. Why would we operate for people with lesser degree of stenosis if they're asymptomatic? That doesn't quite jive. And it's probably something to do with the way that the ACAS enrollment took place. The alternative, which is the common sense approach, which has been around for a while, is to just say 80% is probably an acceptable cut point for doing asymptomatic surgery. That's where it stands right now. Another case. So here, normal common carotid artery velocities, and here we have a peak systolic velocity of 539, so we're really up there, and then diastolic velocity of 117. So how would you interpret this? Well, since we have 539 and then diastolic velocity of 117, believe it or not, it's going to be this. Because there's actually no cut point to basically say it's closer to the end. It's very high, I know, but we don't have, I can't use a number. I can't say anything, unfortunately. Okay, well, things can happen though. Let's look at this one case. So we have a nice plaque. We have peak systolic velocity in the common of 68 before the lesion. At the lesion goes up to 515, goes down to 229, goes back down to 53. The ratio is 7.6. So I think we're comfortable with a really high-grade lesion. Now, again, are we allowed with this ratio of 7.6 and the peak systolic velocity of 5.15 to say anything? Can we say this is near to a subtotal occlusion? No, velocity criteria say this is it. You're in that ballpark. You could suggest that it's in the higher portion of this range, but there's no, in this case, there's no indication that you're getting close to a subtotal occlusion, right? The near occlusion. Those are the people whose velocities drop off, right? So you're not really there. So we still are in this broad category. Now, case 12 is something you're going to have to watch out for. So this is the common carotid artery. That's reading a little bit high in the 100s. The internal is reading 304. 304. And the ratio here we have is 3.8. So you would say maybe this is a 70 to 99%. So 304, 80. Sounds right, huh? 3.8 is below 4. That doesn't make sense. There's something strange about this case. Always remember, as I indicated, to go above. Go above. Now, watch this waveform here. What's the distal velocity? 24. What's the shape of the waveform? Normal or abnormal? It's a bit rounded off, correct? Low velocity, rounded up waveform, distal to a stenosis. How would you interpret that? 70 to 99? Greater than 80? This is the one case where you're going to have to say this. What's happening is that we're not up at 500, right? We've gone back down to 300. But in the process of going down, flow through the distal internal carotid artery has gone down. So we're on that slope, on the other side of the slope where the velocities are dropping. And one of the indices is to look at that internal carotid artery more distally. In fact, it's one of the major reasons to always sample the internal carotid artery. Because when that velocity starts to drop off distally, that means there's not enough pressure to drive the system anymore. That means you're on that, beyond that curve. It's a very important thing to do, and it should be part of your examination. And in fact, this is a tardus parvis type waveform. So it's definitely 70 to 99% stenosis. And I used it closer to 99. I want to communicate to the clinician, you know, don't wait till next month to do something about this patient. This is probably someone that should be seen sooner than this, because theoretically, they're on that curve. They could potentially be at higher risk for occlusion. 13 is a very unlucky number. Here is a case where you have an arrhythmia. What do you do with an arrhythmia? Well, here we have a case where the peak velocity in the internal here is 235, and we've got a nice one here at about 67 in the common carotid artery. Okay? What would you do? The biggest peak? The lowest peak. If you're a cardiologist, you would average things over 5 to 10 cycles. Oh, great. There goes the afternoon. Something else. Anybody have any idea? Well, you didn't listen to Dr. Pellerito's talk, did you? Velocity ratios is one alternative, or the biggest peak. Now you're going to say, come on, that can't really work. Well, the velocity ratio should be done on a consistent, similar cardiac beat. So if you take the biggest peak in the internal, take the biggest peak in the common. If you take the lowest peak in the internal, take the lowest peak in the common. And what I did here is that. I took the largest, 235, and that basically gave me a velocity ratio of 3.5. I also took the lowest here, which gave me a velocity of 125, versus the common, the lowest, which gave me 35 and a velocity ratio of 3.6. So in this case, I would use velocity ratios, but I'd make sure to pick. So I wouldn't pick the highest one here and the smallest one here. I want to pick the same morphology if I'm going to do this. That's an important thing to take into consideration. So the biggest with the biggest. And some people would say you can still use the peak systolic velocity by itself because of the following argument. That beat that has the highest peak is the best cardiac beat that patient can do. That's one of the rules of, that's the highest cardiac output. That means it's closer to normal physiologic baseline. Okay, when you sample the common carotid artery, where do you take your ratios? I think we've gone through this. This is just to remind you that there are 3 levels you could do it at. In the bulb itself, where things are nice and big, so it should be really easy. In the distal common, about 2 centimeters from the beginning of the bulb being defined at the area that dilates. And finally, in the mid-neck somewhere, because it's easy. You always see the common in the mid-neck. Well, The problem with sampling in the bulb is that we get funny flow patterns, reversal of blood flow, and we'll get inconsistent numbers. So we really don't want to do that. So that's not the place where you want to sample it. The problem with sampling in the mid-neck or proximal neck is that the velocities are artificially higher there. It's been observed, it's been published. So we may be underestimating the degree of stenosis. If the velocities are 20 centimeters per second higher, your ratio is going to be artificially lower. So you're going to probably underestimate the stenosis. So the real thing to do is about 2 centimeters. I like to just see the edge of the bulb to make sure that we're sampling right there. And that's kind of a very consistent place and gives consistent results. Okay, let's get away from number 13. Let's try number 14 here. Here's a case of the common carotid artery. There is disease in the common carotid artery. It is possible, and we have to take that as something that we'll have to grade or evaluate. So here, near the bifurcation, we're getting 58 centimeters per second. That's way normal, right? Okay with that? 58? No problem. Now look at this in the middle of the common carotid artery. 252 centimeters per second. Abnormal? It should be abnormal. I mean, 250 in the mid-common. Not acceptable. That's way too high. No, 100, if you're young, 120, 130, maybe 150. Nah, okay. So what do you do with this case? How are you going to grade it? How are you going to report it? What paper are you going to reference to tell them this is X degree of stenosis? Well, you could use the ICA velocity criteria. So it's what did I say, 252? So greater than 70. That make sense? Another way is to say, well, forget about that color Doppler. Let me look at the plaque, and I'll do it visually, because there's not really any criteria for the common. That's going to fly. I'm just going to use the color Doppler or power Doppler. Good alternative. Kind of goes against the principles we've discussed this morning, right? Color Doppler by itself or power Doppler, not really. It's an adjunct. It's something for supporting this, correct? So we don't want to do that. What about velocity ratios? Anybody want to use velocity ratios? This is probably the best place to use velocity ratio. But this is not the same as the velocity ratio we discussed. Up till now, we've discussed measuring the internal carotid artery and making a velocity ratio with the common at a standardized location. Okay. Now what we have is a lesion in the common carotid artery right there. And the ratio, there are two ways to do the ratio here. The first way is to measure the peak systolic velocity before the stenosis, and then at the stenosis, make a ratio of these two, the highest over the lowest. And if it's 2 to 4, it's 50 to 75%. And if it's greater than 4, it's greater than 75%. Okay? And we'll use that. By the way, that's also what we will use in the arterial system, in the straight tube. Works very well. Okay, but I didn't do that. The stenosis was lower down. I couldn't go before it. So I had to do the alternative. I actually measured the peak systolic velocity here, and I went downstream beyond the flow disturbance. So you got to wait. Remember, we discussed the velocity jet earlier on. We got to go beyond the effect of a velocity jet when the flow profiles really renormalize, and we use that value to set us up. And we use same velocity, same numbers, 2 to 4, 50 to 75, greater than 4, greater than 75% diameter stenosis. Okay. And that works for the common carotid. It's very simple. It's practical. No one has complained about it up till now. And I think it's been kind of a very good performer overall. Now, to remind you, this is the article. A lot of our discussions have taken place, have to do with the criteria that were published. And the major emphasis on the cases that I discussed is that if in your lab procedure manual you say, I use this number 1, the peak systolic velocity, 125 or above, if you get 126, you have to basically say I'm following my manual. But you are allowed to qualify it. Okay? Also, you can use the common, internal to common velocity ratio to further qualify the lesion if you feel uncertain. If it's a patient who's younger, who has a higher cardiac output. So you're allowed to use a combination of the criteria, your cut points, for a good reason. And you give the physiological reason in the report. And if you're a sonographer, you explain with a short note what you saw. For example, you'll remind your interpreting physician, because we know they need to be reminded, that this is a young patient, and because of that, the velocities are higher. This is what you need to do, give it in context. So these numbers we've seen before. I mean, they're a good starting point. You don't necessarily have to use them in your own laboratory as long as you have had experience and use them to validate over time. These are the ratios. The 2 is not as solidly grounded. There are really not many papers. Actually, there's no paper that uses 2 as to detect the presence of a 50% stenosis. The real number that's out there is 4 for a 70% stenosis. These end diastolic velocities that are part of this report are iffy. The 100 came out of maybe one paper, and it's kind of iffy when you read the paper. So really what you're going to, for me, end diastolic really means keep in the back pocket, you know, that 140 when you talk about the 80% stenosis. And with that, we've kind of completed our case review, giving you a perspective on what the basic approach should be. The fact that when you use your velocity criteria, you try to be as consistent as possible with what you have listed in your lab manual. And starting from there, you qualify the case to make sure that you don't burn your bridges. Okay, with that, I thank you very much for your attention this afternoon.